Right, so our third session for today is on understanding barriers to TB treatment completion in Kandahar, Afghanistan through qualitative research. Particularly relevant in the wake of global commitment to end the tuberculosis epidemic through the End TB strategy, we have here today to share the findings of an anthropological assessment on barriers of TB treatment, Dr. Julieta Lul Balestra, who is an anthropologist and health promoter. Welcome, Dr. Balestra. Please do aware with the interruption of 5 minutes heads up before the end of your time. You may start your presentation now.
Thank you. Thank you very much. Could you please confirm that I'm heard and
Yes.
also that in a minute I'll be sharing my presentation.
Sure. Yeah.
Can you see my presentation?
Yes. Could you please maximize it?
Yeah?
Thank you. Yeah.
Great. Thank you. Okay, well, good afternoon or morning or evening, everyone. I'm Lul Balestra. I'm an anthropologist, and today I will present you the results of a qualitative study conducted by MSF Operational Center Amsterdam between December 2018 and January 2019 to understand barriers to TB treatment completion in Kandahar, Afghanistan. I will also speak on behalf of my co-authors, Latifa Najafi, Daryl Selmak, and Beverly Stringer. With 72,000 estimated cases in 2019, tuberculosis is a major public health concern in Afghanistan. Nearly 40 years of conflict has seriously hindered the ability to control the epidemic, fueled by widespread poverty and violence, political and economic instability, and lack of access to quality health care. Despite recent progress in TB policy, high mortality, low notification rates, and major gaps in case finding and treatment of drug-resistant TB are still a challenge. Since 2016, MSF has provided TB care in the southern province of Kandahar, torn by a long-standing conflict between the Taliban and government as well as foreign forces. Based in the provincial capital, the second largest city in Afghanistan, MSF supports the Afghan Ministry of Public Health through screening, diagnosing, and treating drug-sensitive TB cases in a regional hospital, a provincial tuberculosis center, and a prison, and assists rural facilities for diagnosis of pulmonary TB and presence of resistance for rifampicin. MSF also runs its own TB center, where short and long-course drug-resistant TB treatment regimens are offered. At the time of research, MSF promoted acceptance of drug-resistant TB care through various measures, including accommodation in Kandahar during the intensive phase for patients coming from far, and the options of a self-administered treatment approach in the continuation phase, along with transportation allowance and food parcels. In spite of the positive outcomes, use of TB care remained low, and treatment refusal and loss to follow-up, meaning people interrupting treatment, high. For this reason, and seeing the paucity of focused research in Kandahar, MSF Operational Center Amsterdam decided upon conducting an anthropological assessment to better understand local perceptions of TB disease, transmission and treatment, as well as the health-seeking behavior of local populations, and to provide information needed to develop appropriate and effective community prevention and treatment model of TB care. The assessment used a purely qualitative research methodology, as this is particularly well suited to investigate the complex dynamics of social phenomena, including the social processes and cultural representations of health and illness. In-depth interviews were used to engage with people with TB and their families, as well as with health authorities. Focus group discussions gather diverse views from community members and leaders and health workers. Interviews and focus groups involved a total of 146 participants and were conducted based on the flexible use of a topic guide. Non-participant observation was also used to underpin the reality of TB care at the facilities, and numerous informal conversations were included in the body of data. Participants were selected purposefully, so based on specific attributes like their TB status or their gender, for instance, to ensure diversity of perspectives. Convenient sampling, so participants selected for availability, like when visiting the TB clinic, was also employed. The data collection team consisted of myself and 7 local staff members, all trained on the purpose of the assessment and its qualitative methods. Data was mostly collected in local languages with translation when needed. To ensure ease of the participants in a highly gender-segregated society, data was usually collected by a researcher of the same gender of the interviewees. Due to security restrictions, data collection was mostly conducted in clinical settings and the MSF office. Data recorded through interviews and focus group notes, as well as field notes, were analyzed using grounded analysis, allowing themes to emerge from a close review of the material. As this was a targeted assessment for MSF internal use, it was considered exempt from ethical review based on criteria at the time of the assessment by the medical director. The research team took all reasonable measures to cause no harm, including through properly informing all participants on the purpose and process of the study and the rights to decline, and ensuring that data was handled confidentially. So now to the findings. Illness narratives reveal the interrelated influence of various factors at the personal, social structural, and health system level in hindering adherence to the continuation of TB treatment in this context. It might be worth noting up front that features at these levels overlap in many ways, reflecting the complex nature of reality as opposed to categories used for analysis. Having said that, at the personal level, perceptions of the TB treatment could influence adherence to a great extent. Stopping the treatment when feeling better was common, especially among men who were often eager to resume work. TB drugs were often perceived as strong and potentially harmful, and this had influenced the choice of, for instance, the family of a pregnant woman to stop her treatment. Lack of knowledge of the gratuity of treatment in public services had led some persons with drug-sensitive TB to delay initiation until the default, especially if they had been diagnosed at a private facility, a common occurrence in this context. On the opposite side, defaulting from treatment started at a public facility seemed to be facilitated, in some cases, by drug-sensitive TB drugs being also available in the private sector, which might simply mean at the bazaar, the market, where, however, the quality of both the drugs and the follow-up is very low. The reason for not receiving the whole treatment at once and the need to return to the facility monthly for drugs collection and medical follow-up under a self-administered regimen were not always understood or appreciated, especially if associated with common issues with accessing medicines in this context, as recalled by a community member in this quote. In the public sector, they have few medicines, and they only give them to inpatients and important people. The rest get some medicines, and then they send you to buy it in the bazaar, or they tell you to go to their private clinic in the afternoon. Side effects and lack of improvements could be discouraging and lead to defaulting, particularly in case of lack of trust towards health workers, which was quite common in Kandahar, especially in public and rural facilities. For instance, an MSF health worker recalled, "We had a pediatric patient. She had side effects, and so she was brought to a private doctor. We tried contacting them, but the father said, 'You gave us expired medicine, and that is why my kid has side effects.'" Often side effects and lack of improvements were interpreted as proofs of incorrect diagnosis. In these cases, people with TB would often search and find an alternative interpretation at a different doctor or at a mullah, religious scholars who are experts in the medicine of the Prophet and highly respected by local societies. For instance, a loss to follow-up patient with resistant TB recalled, "After I left the treatment, I went to the mullah. He said I hadn't behaved well and I should do some charity, but it didn't work. After that, I went to Pakistan. The doctor said that I don't have TB and that I am anemic. I have typhoid. They gave me treatment. Now I'm very healthy." Rejecting the TB diagnosis was also compounded by lack of acceptance of a highly stigmatized disease, often perceived as deadly and caused by unhygienic, unhealthy, and generally careless behavior, and associated with already marginalized populations such as women, rural and nomadic populations, here called Kuchi. The high incidence of mental health issues in a conflict setting was also said to have a negative influence on patients' adherence due to struggles with self-care and lack of commitment to the TB treatment. At the socio-structural level, several issues of access negatively affected TB patients' adherence to treatment. Most often, these included distance from the clinic, lack of financial means to access health services or buy drugs when that was the only option, and conflict, leading to fighting, roadblocks, and movement restrictions, forced migration, militarization of clinics, and generally the prioritization of TB care. In this quote, a community elder living in a rural setting shed light on some of the difficulties that many people face and on the reasons for preferring more substantial drug supplies. My place is very far. The roads are closed due to security. TB is one of the biggest concerns, but there is no transportation. We come very rarely to the city. So when we do, we take medicines for 4 or 5 months.
Last 5 minutes.
Okay, thank you. TB stigma could considerably hinder adherence. Due to their marginalized position in society, women with TB were more likely to face abandonment or limited support from their husbands and in-laws, with whom they usually live after marriage. Reflecting on TB stigma among women, a female activist for women's rights said, "If a woman gets TB before marriage, she'll have low chances of getting married. If she gets it after, the husband family will hate her, and there is a good chance that the husband will take another wife and will not get her cured and let her die." It was interesting to notice that several women had started treatment during a period spent at their parents' house and had defaulted from it after returning to their marital home. For instance, a young girl with drug-resistant TB feared for her ability to continue the treatment after the end of their stay at the patient's guest house and her return at her husband's place, since he and his family had not supported her at symptom appearance, but had rather sent her at her parents' house, whom they considered responsible for her sickness. At the health system level, health workers perceived rude attitude that contributed to some patients defaulting from TB treatment. This was especially common in public facilities, where discrimination of TB patients was said to be frequent, especially by individuals living in rural areas and nomads. Lack of confidentiality was found to be an issue during consultations in some facilities and during home visits in nomadic groups. Besides, the way prevention messages were communicated by some medical staff could increase stigma. For instance, a female patient who was lost to follow-up told us, "The doctor said to my family, she has TB and you should stay away from her. So they were not eating with me, they separated my room and my plates. They were not talking to me anymore, and this situation was really hurting me. So after 1.5 months, I decided to leave treatment." The shortage of female doctors contributed to female patients receiving worse TB care. Women often lacked direct access to health workers due to the inappropriateness of male-to-female physical examination and the need for the husband's mediation. For instance, a female TB patient whom we met outside the facility reported never having seen a doctor after her diagnosis, and only coming to the facility to have her sputum tested while her husband talked with the doctor and collected her drugs. Later, her husband told us, "She tells me how she feels and I report it to the doctor." Women will not speak freely to doctors. If there was a woman doctor she could go, a male doctor is no good. This was said to be an even more important barrier in rural areas where female doctors are extremely rare. The centralized model of drug-resistant TB care was a huge challenge for most patients and family members, especially due to the inability to attend to gendered responsibilities and the stigma attached to it. So for women, defaulting during the intensive phase was often linked to responsibilities at home and children care, while reduced income due to lack of work while in Kandahar was a major reason for loss of follow-up of male patients as well as of children and female patients with male caregivers, often under pressure by older male relatives in a position of authority. In other cases, missing the family or feeling bored while in Kandahar had led to default. Several shortcomings decreased the effectiveness of treatment support measures in rural areas. For instance, community health workers coordinated by a local organization had the important task to deliver and monitor drugs intake at home as per the directly observed treatment approach (DOTS), but this was hindered by the lack of personnel in some areas and their voluntary role. Also, the discontinuation of food parcels previously provided by the World Food Programme to drug-sensitive TB patients had represented a challenge for many. For their precarious socioeconomic conditions, nomadic populations, Kuchis, were said to contribute disproportionately to TB, as well as to numbers of loss to follow-up. Thus, it is significant that health workers were reported as showing a lack of sensitivity towards their seasonal migration. For instance, 2 Kuchi women said during a focus group, "The doctors are frustrated by knowing that we will move, so they say, 'Why should I even give you the treatment? You're not going to complete it anyways.'" And another said, "There are clinics where we go, but they tell us to go back to where we started the treatment." Even more importantly, there seemed to be a lack of adapted strategies of the health system to Kuchi's lifestyle. In fact, against obvious issues of access to quality services in various phases of the migration, several sources suggested that Kuchis may be underreached by mobile clinics and mobile teams, as well as by community health workers. So limitations of the study include short time available for fieldwork and the highly insecure context that prevented a closer approach to the field. Data was collected by local MSF employees and a European female anthropologist, and this may have prevented some participants from sharing sensitive information or critical opinions toward the organization. Exploratory findings are not generalizable to all contexts, but may highlight similarities with other populations living in crisis settings. It should be noticed that this limitation derives from the chosen methodology's major strength, which is to highlight features that are relevant to a specific context. So, in conclusion, this assessment has shed light on some of the many barriers experienced by people with TB in Kandahar in continuing TB treatment. The development of locally relevant strategies and the patient-centered approach are crucial to improving treatment adherence. In this context, and based on our findings, these should include the following aspects. First of all, the implementation of a decentralized model of TB care to improve access for patients from remote areas in a context marked by reduced mobility and financial hardship as a result of conflict. Then, the promotion of context-sensitive TB awareness and patient education and counseling. This should be systematic and sensitive to existing forms of marginalization related to socioeconomic status and gender. This should take into account the power dynamics within families and societies and engage the main decision makers, in this case largely men and older family members, as well as influencers, for instance here mullahs, religious scholars. TB awareness and patient education and counseling should also minimize stigma in and outside the family, for instance through communicating prevention messages in an encouraging way and promoting a positive role of TB patients in their communities as a much-needed source of TB knowledge. TB awareness and patient education and counseling should also aim at promoting trust in healthcare workers and facilities, an essential component of adherence to treatment. Lastly, specific support for mental health issues common in conflict settings should also be provided as part of TB care. The adoption of measures to increase the accessibility of treatment by vulnerable populations, including women, rural and nomadic populations, is crucial. With regards to women, the employment of female health workers is recommended whenever possible, as well as community outreach to minimize the health impact of reduced mobility. Healthcare strategies that take into account the social and economic priorities of nomadic populations are particularly indicated. This should be developed based on a deeper understanding of their social structure, lifestyle, and migration patterns, and include coordinated work among facilities along the migration routes, community outreach, and community engagement as pivotal components. Lastly, strengthening treatment support measures is crucial in a context marked by such barriers to TB treatment completion. The appropriate support and incentive of community health workers are particularly important for their unique role of proximity. Forms of support, including food parcels and financial support, should be considered and implemented flexibly. So briefly, since the time of research, many things have changed both in the MSF response as well as in the broader context of the intervention. One of the most important developments is certainly the introduction of a new drug-resistant TB treatment regimen that has improved access considerably by eliminating the need for injections, hence for long stays in Kandahar during the intensive phase. Stronger collaboration with rural health facilities and community health workers, including some of who are working with Kuchi population, is also ongoing. On the other side, the COVID-19 pandemic has only worsened the barriers highlighted in the study, as also recalled previously by Dr. Farad, particularly those related to mobility and economic instability, and has hindered the ability of MSF to adapt their response, for instance by delaying the planned decentralization of drug-resistant care to neighboring Helmand province, where MSF operates, and where most of MSF Kandahar TB center patients come from. Besides, the upsurge of the conflict that now sees the Taliban much closer to both Kandahar and Helmand has increased the challenges. In this context, a flexible and proactive approach to supporting TB patients is needed more than ever. We want to acknowledge the contribution of the Kandahar data collection team members, the MSF and Ministry of Public Health staff involved, the whole project team, as well as the coordination and desk team members at the time of research, some of whom are named in the presentation. I also want to personally thank Darren Stanmack and Beverly Stringer for their guidance and Kate Hughes for the literature review. And of course, our first and biggest thank you go to the participants of the study who have shared their sometimes painful experiences with TB with us. Thank you all for listening.
Thank you, Dr. Ballester, for such an observing presentation. So we have a couple of questions from our audience. This anonymous user wants to thank you for this presentation and is asking, is there a possibility to introduce telemedicine in the Kandahar ecosystem so that personalization of health services is possible?
Sorry,
Sure.
could you please repeat the question?
Sure. So is there a possibility to introduce telemedicine in the Kandahar ecosystem so that personalization of health services is possible?
Right. I mean, I guess that, first of all, I should warn that today I was supposed to be here with my colleague Latifa Najafi, who's a local staff member. So I was also counting on her to sort of back me up with some of the answers to questions that are more related to what is happening now on the ground, since I haven't been on the ground since January 2019. But back to your question, I think that could definitely be a possibility, something that might apply to more urban settings, although rural settings might be more challenging due to technological and connectivity issues. But that is why there has been a lot of work going on in the last year or so to strengthen the link with rural health facilities and provide increasing trainings based on a prioritization of areas where most patients are coming from, to sort of increase the support given to rural health facilities and rural health workers to build their capacities to fight TB at the facilities level.
Right. So there are multiple of questions here. So first, they would like to know the total TB patient cohort size. So would you please allow?
Yeah, I'm afraid I don't have that data right now.
No worries. So all right. So another question is that what are the necessary steps taken after the study to mitigate the barriers identified here?
Yeah, so as I said, one of the most important measures that was taken was to upscale the collaboration with the rural health facilities. As we said, as you saw that that was, I mean, one of the most affected population. Another very important recommendation was the decentralization of TB care, and especially of drug-resistant TB care. That was approached by conducted an assessment in Helmand province to understand and plan for the decentralization of drug-resistant TB care in the continuation phase. And a plan for implementation of decentralization was developed, and that would have started with decentralization of post-treatment TB care, in order to build capacity of the structures to then be able to also decentralize continuation TB care in continuation phase in Helmand province. But that was unfortunately was done just right before the start of the COVID-19 pandemic, and so the whole plan was kind of put on hold. Another very important component is to strengthen the collaboration, as I mentioned in the presentation, also with the community health workers. Since MSF obviously faces very serious limitations in working directly in rural areas, and in general in the community, even in Kandahar city. And so a collaboration with the local organization coordinating community health workers is ongoing. And MSF is now organizing trainings with community health workers 2 to 4 times per year, and supporting them in their work.
Thank you. Mukata Sikubova wants to know that, did you use translators or local staff were doing it directly?
Yeah, both actually. Some of the interviews and most of the focus groups with communities were done directly by local staff. Some of the interviews were also done through phone, so obviously it was preferable for local staff to do the interviews directly, seeing the already existing challenges in communication, and establishing also a relationship with persons who often were lost to follow up, so they were not in touch with the clinic anymore, but anyhow were available or made themselves available to speak with us and tell us their perceptions and their experiences. So yeah, in many cases that was done directly in local languages, directly by local team members. As I said, 7 local team members were project staff, already existing project staff were recruited and trained for that purpose. Some other interviews obviously were co-facilitated by me and the local staff, and in that case, there were few interviews made in English directly, but in those cases, a translation was used.
Thank you. So, okay, one last question because we are kind of out of time. So this is from Dr. Stubdan. Thanks for the interesting study. The barriers you highlight are a wide range of factors, some specific to local context. Did the project undertake or plan to do any quantitative studies to assess which of these factors contribute the most, so as to prioritize activities to address these barriers?
No, not to my knowledge. No, that there wasn't. There was a, and that was actually sort of highlighted by the study as well, or at least emerged during the time I was there for research. The lack of quantitative data in terms of Kuchi population, nomadic population. Yeah, Kuchi population. How many among the patients were Kuchi or nomadic? So that was something that had been looked into, and there was some discussion about inserting starting to collect that data as part of routine data collection, and then analyzing that data as well. But yeah, that's about it.
Thank you so much, Dr. Galessa, for such a compelling, multi-layered findings at a social, socio-structural, apologies, personal and health system levels. Thank you so much.